Okay, so welcome everyone. So did you guys all get something to eat? You're well fed? You are now no longer grouchy. I know you all came in kind of looking grouchy, but I'm glad that you're no longer grouchy. So I'm Peter Lamb, I'm a family doctor, and I've had the pleasure of working with the Peter Munk Foundation on this program from the beginning. So this is now the fourth annual meeting because you guys said that we would like this annually. And the faculty and the staff at the Peter Munk Center, as well as the UHN group, has been very kind with their time. To go over a couple of things. One is there's a green evaluation form, so just make sure you fill it out along the way. Otherwise, they all start looking the same and sounding the same. And we certainly like feedback because every year we try to increase, sort of the content to make sure that it's applicable. I remember the very first year, this was very much a show and tell. In other words, look at all the wonderful innovation that's happening at the UHN. And then there was feedback that says, we love the innovation, but give us some practical tips as well. And so therefore, the program has been evolving and morphing based on your feedback. There are also lots of these nice printouts that tell you all the interesting places that you can connect with the Cardiac Center in the Peter Munk location. So therefore, you can have many of the referral numbers and things like that for your available for your office. And just as a reminder that there are credits for this. If you're part of the College of Family Physicians, there's 10.5 Main Pro 1 credits, and you'll get that tomorrow at lunch, so you can't, or tomorrow at the end of the day, so you can't skip out. There is an iPad draw, okay? So the BMO people have been very kind, and they have an iPad draw, so you can actually put in your little card or whatever, try and write legibly, like not like doctors and that kind of thing. And then what you can do is there'll be a draw tomorrow at lunch, and you have to be here to actually get it. So if your name is drawn and you're not here, sorry. So just to finish off, I think last year I told you guys I had a fracture, so I'm going to continue my saga. So I had a fracture and I had a compression bolt put in because I blew my mortise. So anyway, so they needed to take out the compression bolt because it's going to fracture over time. So anyway, so they had me going back into surgery about 6 months afterwards. And so while I was there, they wanted to give me, the very young resident came in to see me from anesthesia, and he said, Dr. Lin, we need to talk about your anesthesia needs. And I said, it's just taking out a bolt. Can't you just give me the propofol, the Michael Jackson stuff, and then we'll be done quickly? He goes, no, you'll be in a lot of pain. So I said, okay, fine. So he says, I suggest a spinal. And I thought, wow, a spinal just to take out a bolt. He goes, no, you'll need it. So I said, fine. So we're walking down to the block room, and he turns to me, he goes, when do you get used to the cold here? And I said, what do you mean? How long have you been here in Canada? He goes, about 2 weeks. I go, what are you doing here? I'm learning how to do spinal blocks. So I was sort of stuck at that time. And the reason why I say that is because if you look at the agenda that you have in front of you in the binder, you've got the top notch of everybody coming to this meeting and speaking to us. So that's why I think this meeting has been very well attended, spread over 2 days, only because we have so much content to go over. And so this meeting has sort of gotten a very special place in all of our practices because it's the beginning of the year, and we start off with not only practical information, as you see with the topics, a lot of them start off with office-based management of whatever the disease is. And then we always finish each section with an innovation. In other words, what's new, what's happening, sort of the cutting edge stuff. So therefore, we're up to date in terms of at least on the horizon what might be coming, so that when patients come in and say, I Googled and I saw this, we can say, yes, I was at a meeting and we talked about that. So it'll give us that sort of up on top of our patients. So to get us started, I wanted to introduce Dr. Barry Rubin. And just to give you some background, he's a surgeon, but he does everything. So he's won all these awards that only Americans can win, and so therefore he must be good. Thankfully, he comes and hangs out with us a lot, and basically he controls, or he looks after, he never says controls, he always looks after 600 physicians at the Toronto General Hospital, Toronto Western Hospital, Princess Margaret, and Mount Sinai Hospital. He also deals with the government. Last year, he was a lightning rod where he actually took on the whole MS in terms of whether the procedure works or not. So he went into a room, it was like walking into a thunderstorm with a high pole, like a metal pole, and that's what he did. And he walked out of there with the respect of all those patients with multiple sclerosis. And we actually talked to some of these people afterwards, and they said, him we trust, everybody else we don't trust. So it's very interesting that he has not only the stature of the position that he's in, but also the trust of physicians as well as patients. And so we thought we'd have him sort of, he's the head of everything, I guess, come and give us some words to kick off this session for us. So Barry?
I honestly have no idea how to follow that introduction. That's very kind of you. So I'm really looking forward to this year's symposium, and thank you all for coming. There's a lot of work that goes into this. This is led by Narinder Paul. So thank you once again, Narinder, for putting this together with Shanice Mohammed and our program committee, Mike Farku, Tom Lindsay, Shanice, Kumar Nanthakumar, Gary Newton, and Bert Wintersberger. So we have a breadth of topics to discuss with you, and I'd like to emphasize the focus on innovation. So we're going to talk about a lot of things that you're going to see commonly, and then we're going to talk about some really new things. And the timing could not be better this year. For the innovation session tomorrow, Terry Yao is going to talk about injecting stem cells harvested from a patient's own bone marrow into the infarcted area of their heart during heart bypass surgery. And there was a story about that today in the Star. So that's really exciting, the potential to rebuild damaged hearts. And we're also going to have an additional talk on renal denervation therapy. So this is not in your syllabus, but it's a very hot topic. This is for patients that have pressure systolic over 160 on 3 medications, and medication isn't working well. Slip a catheter into the renal artery and denervate the nerves with a catheter, and this has been shown to control hypertension. And we did the first case in Canada last week, and we're going to have a special session just devoted to that topic and tell you how you can refer patients if you like. So I hope you enjoy the program. Remember, there are CME credits available for this, and please fill out your evaluation forms. Do you want to come back up and introduce the first speaker? That would be great. Thank you very much.
Okay, so the way it'll work, we have 5 sections or blocks, so we'll have a chairperson for each block. We'll go through that, and then there will be a break and question-answer period. So please write down any questions that you might have in a legible way, and then that way we can deal with that in the panel discussion. And then there will always be an innovative talk looking at the latest and greatest. So to start off our first section, which is health promotion, which came up pretty high on the evaluations from the previous years, is saying how we can actually improve by preventing disease from occurring at a primary care level and so on and so forth. So Mike Farku, the first time I met him, that's all he talked about. He talked about diet and exercise, and that's unusual because he's the director of clinical trials at the Peter Munk Cardiac Center. He's the director of cardiovascular clinical trials at University of Toronto. He's a scientist at the Lee Kai-shek Knowledge Institute at St. Michael's Hospital. So heavy duty, lots of clinical trials, and here he is talking about lifestyle and things like that. So I thought that here's a cardiologist that deals with acute coronary syndromes all day long, a world-renowned expert in the area, and yet talks like a normal person. And so that's when I thought, hey, Mike is going to do great things, and that's what he has done now. So perhaps I can have Mike come up, and then he can go through health promotion and the 3 or 4 lectures that we have there. So please welcome Mike.
Thank you very much, Peter and Barry and everyone who helped to make this possible. We're very happy to start with health promotion because we think that is the cornerstone of where our healthcare system is going. And we believe that we can play a role in it at the Peter Munk Center. And the first talk is going to be by Dr. Mike Domanski, who's an old colleague of mine, old in the sense that we worked together for a long time over the past decade on some important clinical trials. Mike is a pioneer in many of the ways that we evaluate new therapies and new strategies for treating patients. He is he's board-certified interventionalist, a board-certified heart failure expert, and a board-certified imaging expert. So Mike really understands the scope of cardiovascular disease. And interesting enough, despite all of this and spending 23 years at the NHLBI, he really does relate to what happens at the ground level. That's really where Mike works well. And his passion has been health promotion, as it has been in my career over the last 5 years. Mike's been a major mentor to me in this regard. And together with Valentin Fuster, we're now undertaking the ECAD trial, which is the Eliminate Coronary Artery Disease trial. Mike is really the leader who has spearheaded this movement and has spearheaded the idea that family physicians can be involved in research. So Mike, we look forward to your talk, and thank you for coming.
Okay, well, Michael, thank you for that generous introduction. It's a pleasure to be back in Toronto, and your beautiful city, really by the lake, and it's a real privilege to be part of this Peter Munk Symposium. The Peter Munk Center is certainly, clearly one of the really nimble research organizations that's been assembled. You have the research infrastructure to really move forward, attack important problems, and solve them. So again, it's a pleasure to be here. I was asked to talk a bit about a couple of things, 2 or 3 things that appear somewhat disparate, but for which there is a good segue. That is some observations perhaps on family practitioners and their role in research, and also talking a bit about the ECAD trial, and also the broader theme of prevention. And I do want to emphasize the latter, partly because I'm passionate about it. I really think that we have at our disposal tools today to make major strides in preventing disease, and that's really a theme that I want to put forward. So I'm a little worried about talking to a group of family practitioners. I don't have credentials as a family practitioner. I'm a cardiologist, but I think my standing to speak to you today about the role of research for family practitioners relates more to my background as a clinical trialist and as a clinical investigator. And so I hope that I can, say some things that are useful to you. Now, the question was that I had, and I actually spent a fair amount of time thinking about how to organize my thoughts that related to this. And I thought one way of thinking about it is to ask, if one were, for instance, in charge of or responsible for a family practice program where there was an emphasis not only on providing the excellent clinical care that, of course, everybody wants to provide, but also perhaps on also moving back the research frontier, what would one want to do? And what research would one pick? How would one go about that sort of thing? Well, so there are 3 elements if you're going to define a role for yourself, I think, in research, for a program in research. And one is the interest of the people that are involved in it. Different organizations are obviously going to have different interests. Of course, one has to provide medical training and experience and a medical practice in the appropriate way. And finally, no matter who you are or what you're doing, if you're going to do research, you have to understand the methodology that attends it. So I want to consider each of those things in the context of family practice. So let's talk about interest first. And I think if one's asking about a role of family practitioners in research, then one has to kind of think about who one is dealing with. I mean, who goes into family practice? Well, my sense of that is people who have certain interests. Specifically, for openers, they're interested in direct patient care. They really want to see patients. They want to kind of be real doctors seeing real folks. And secondly, they're interested in diversity of practice. They're not people who want to spend a lifetime sewing bile ducts together. And it's important if you need your bile ducts sewed together. But they're people who are interested in really seeing the diverse spectrum of disease and not be confined to one thing. I mean, my career is a little bit like that, although it's confined to cardiology. It's I really am interested in imaging, and yes, I'm interested in angioplasty, and I'm interested in a variety of things. So I can identify with not wanting to be pigeonholed into one area. And also, I think family practice people are people who want to deal with human beings. They're not people who are going to be nearly as happy in a basic science lab breaking glasses. As important as that is, it's seed corn for the future and all that sort of thing. But the fact of the matter is they're people who want to deal with people. So I think that if you're talking about a role of family practitioners in research, I think it's probably likely to be clinical research. That's most likely to be the focus of individuals who go into a specialty like family practice. And clinical research, of course, has a broad spectrum, from translational research, where one's really bringing laboratory understandings into the clinical realm for the first time. Of course, clinical trials, where we try to understand their usefulness in treatment. And finally, in understanding how one can actually deliver those services across a population. The latter being entirely non-trivial and in many ways critical to actually getting the bang out of a useful research understanding. If you don't deliver it, it really doesn't do much other than provide some intellectual interest. So I think that's who goes into family practice, and I think it's probably in the clinical research realm that family practitioners are going to find their most natural niche. What about medical training and experience? Well, that's interesting, because one could ask, what do family practitioners do, and how are they trained, and so forth? Well, the truth is that the practice of a family practitioner generally includes multiple specialties: internal medicine, pediatrics, surgery, etc. And in point of fact, the experience that you have as you see your patients out in the community is that you see the problems that afflict real people. You see the real epidemiology, not, you see rare diseases rarely, and you see common diseases commonly. So you're seeing the heart attacks and the strokes, the atherothrombotic disease. You're seeing people with cancer. I would classify aging as a disease. That certainly could invoke some argument, I suppose, but I would regard aging as a disease, and certainly in a very real way, you see the ravages of that disease in your own practice as time, as you watch your patients over the course of years. And of course, infectious disease. So you actually have an interesting view of the entire health frontier, and that's a perspective that is, is not universal with respect to medical specialty. So these are people with a real view of the real world that's out there, and I think that's quite valuable. Now, when it comes to research methodology, doing clinical trials it really is a team effort. One needs a lot of different skills to do clinical trials. One certainly needs physicians, but you also need statisticians and clinical trialists and nurses. Indeed, our basic science, our clinical trials are a wonderful platform for elucidating in the sub-studies additional basic understandings. We certainly need clinical site PIs, people who indeed recruit the patients and follow them along from day to day. But it really is a choir, and the choir doesn't sound very good if all the singers aren't there and kind of doing it right. It really is a team effort. And I think the background of the people varies. I think family practitioners have a role. I think cardiologists have a role. I think that nurses have, I think there are a lot of people who have a role in these things. So it's genuinely a team effort. I do think that if you're interested in doing clinical research, certainly if you're interested in leading clinical research, like anyone else, I don't care whether you're a family practitioner or an endocrinologist or an oncologist, you really do need some background in research methodology. And certainly if you're training young people, some time and some effort needs to be devoted to that. Again, I think that's kind of not specialty specific, but it certainly applies to people in family practice. All right, well, now I want to shift gears a little bit and talk to you about our ECAD trial. It's elimination of coronary artery disease, and it may be that we should say the mitigation of coronary artery disease or something, because I don't know that we're going to wipe it all out, but I think we can make major inroads, and that's certainly what we seek to do. Now, again, I want to emphasize a theme, and the theme that this study fits into is preventing disease with risk factor control that's under our control at this point, but probably hasn't been used a great deal in that way. So I'm going to sort of start from first principles, and again, I do stand some chance of ending up like the beaver in the second slide, but I want to put forth sort of a concept if I could, and I'm going to ask the question: what is it that kills people? I mean, what in the end ends their lives? And the things that I've put up in front of you is probably from the 20,000-foot level a view of what ends people's lives. And I've tried to organize it in what I think is the increasing difficulty of actually solving the problems. I mean, trying to actually make some inroads. So if I were a young guy starting out and I said, look, I really want to make a difference and I want to do it in my lifetime, I want to leave footprints in the sand, what should I attack? I mean, which of these things really is amenable to attack, and how? Well, let's think about it for a minute. Let's think about atherothrombotic disease, basically heart attack, stroke, vascular disease, coronary heart disease, cerebrovascular disease. If my background before I went into medicine was engineering, and so if I'd been told in my aerospace engineering days, I want you to design a system to get rid of the obsolete human beings, get rid of them as they age. It's an obsolescence engine, and I'd like you to do that by blocking up their arteries. Now, I have to design a machine to do that, and it's not so easy to do that. I mean, we've all, unfortunately, got that machine resident in us. But, if you told me to do that, again, it's a machine with a lot of moving parts. There's the LDL that has to get into the endothelium, then it has to be chemically transformed. An engine has to make these plaques. If you think about it for a minute, it really is a pretty complicated machine, and it's one we'd like to do without. but it is a complicated machine. And in fact, sort of conceptually, if I can just do away with the function of one of those moving parts, all of a sudden, I don't have the machine anymore, okay? And that's what we'll be talking about with ECAD, but let's go back to my little diagram, and let's think about cancer. Cancer is a totally different game. Here, an extraordinarily delicate automatic control system is deciding when cells are going to replicate. And if you lose that very delicate machine, well, you got another delicate machine, but it's doing something different. This is the machine we actually want. There are many things that can mess up its moving parts. You lose control, you've got cancer. Very different, and a much tougher nut to crack, because instead of now building a machine that I can abort, or dealing with a machine that's function I can abort, now I've got a machine that I want to preserve. And I propose that that's a fundamentally different question. And I think that's a tough one. I think it's much harder. And if you move on to a thing like aging, now we don't even really fully understand it. And to talk about, in a clinical setting, trying to do anything really substantial about reaching into the genome and stopping the clock is simply visionary. I'm not going to see that, neither are you. I don't think. I mean, you know, I could always be wrong, but short of a remarkable breakthrough that's totally not predictable, we're not going to see that. What about infectious disease? Infectious disease is interesting because there have been major strides made in infectious disease, and there are more that are possible. Infectious disease is an odd one because there's the potential for something to crawl out of the jungle, or worse yet, out of a biological laboratory somewhere and simply wipe the slate clean. I mean, that the infectious diseases pose a potentially existential risk. I think that's a different discussion. Okay, and that's not one we're going to have today, but it may be one worth having in a different venue. All right, so let's go back to atherothrombotic disease, because that's what I want to address, and that's what we're addressing with the ECAD trial. You know, in the lifetime of a child born today, or alive today, my kids, for instance, atherothrombotic events, heart attacks, strokes, et cetera, are going to kill more people than all the wars of history. Now, I researched this, actually. I wanted to be able to say 10 times. It's actually not quite that, but it's massively more. You know, that's a remarkable amount of carnage. We have, in Washington, where I lived for many years, we have, you know, monuments to the people who died in all sorts of wars that we've been engaged in. None of them come even close. There's not a single monument to atherothrombotic disease, but, you know, there sort of ought to be. It really is a remarkable statistic. And the question is, can we do something about it? Well, first of all, what can we do about it? You know, we've made real strides. You know, it's very satisfying to put stents in coronary arteries. They really look better when you finish. But the real truth is we're not going to stent our way to a cure of coronary disease. It has limited potential in terms of cure, and I'm not picking on stenting. Just in general, treating established disease is going to take us probably only so far. So we probably have to prevent it as an ultimate strategy. And the fundamental question that we're facing is, can we, with therapy available today, either eliminate or remarkably mitigate coronary artery disease as a major public health problem? And I think there's a fairly strong signal to suggest that that may in fact be the case, that it may be possible to do that. So let's think about the signal together a little bit, and then I'll say a couple of words about the ECAD trial. Well, once again, let's go back to my engine. You know, the fuel for that engine is LDL cholesterol. It's an important fuel for it. And so the notion is perhaps no fuel, no fire. The LDL gets into the lining of the vessel, into the endocardium. It's chemically transformed, and a plaque ultimately forms. We know that if you reduce LDL, you reduce plaque formation. In fact, that's a central paradigm, clearly, of treatment of established coronary artery disease and of preventing it. So the notion is, let me do that. The notion is that if you could go very low with LDL cholesterol, perhaps you could eliminate the disease, or at least, again, reduce it substantially. So let's look at some of the data that might support that. And this is not an attempt to be encyclopedic about the data in the field, but sorry, guys. Fortunately, you're not flying what I'm doing here. Okay. So if one looks historically at the hunter-gatherer crowd, and these folks who are operating with LDL cholesterol is probably in the 50 to 70 range, what one sees is very little coronary disease. I mean, if you look at, for instance, the last of those, these are autopsy series. And I bet you that I'm the only person who quotes the East African Journal of Medicine from 1937 today, okay? But that last one, the autopsy series from Kenya, is very interesting. I mean, it's 1,000 patients, and it's not great science. The article doesn't give you some of the things that, you know, the New England Journal would ask you to have in this day and age, for sure. But that said, they just didn't get the disease. Now, there are other things about the hunter-gatherer lifestyle, but an important one is they were operating about where neonates are in terms of LDL cholesterol, and they just didn't get the disease. So one would think that if one recapitulated that sort of LDL cholesterol, one might be fairly successful in preventing the disease. And indeed, if you look at the epidemiology from a more modern time, this shows 3 studies, there is a strong graded association of LDL cholesterol with coronary heart disease event rates. And that, okay, oh, I'm sorry, yeah, I'm not, you know, we're separated a bit by the barrier of a common language. You know, right, we think in milligrams per deciliter, and I know you can think in millimoles per liter, and I've actually started to get good at that because I can divide by 39 point whatever it is. And, but the point, the larger point is that there's a strong graded association, regardless of the units, and one sees that throughout the epidemiologic literature. Now, if you look at the primary prevention studies that are out there, there is again, same thing, strong graded association of LDL cholesterol achieved and coronary heart disease event rate. Okay. Now, so there's a message, and the message is lower is better. I mean, it's pretty straightforward, I guess. Now, what about, but lower when? Okay, so let's ask the question, PCSK9, okay? PCSK9 is a gene that codes for an enzyme that breaks down LDL receptors. So the more robust your PCSK9, the fewer LDL receptors and the higher your LDL. But there are people who have a nonsense variant of that, and it lowers their LDL. It doesn't lower it a whole lot, but people who have that mutation have more LDL receptors, and they have a somewhat lower LDL cholesterol. Why do I care? I mean, why am I citing a gene in this discussion? I'm citing a gene because you get that from day one. This is early. This is right away. It's not a bunch of old folks who got, you know, who got simvastatin or something. It's something you get from day one. And what happens is interesting. What happens is, correlate yellow with yellow because it's the different races. And what you see is, if you have a nonsense mutation of PCSK9, your cholesterol level is lower. And in the case of blacks, it's way lower. And in the case of whites, it's quite a bit lower. And in point of fact, if you take the next step and you plot this is a kind of a homegrown plot, but I think it's an interesting one. What it shows is, it shows the primary prevention trials in blue. It shows the hunter-gatherers with their little triangle way down at the bottom. And it shows the PCSK9 people from the 2 races. Notice that, again, strong graded association of cholesterol level achieved with event rate, but something else also. You know, the reduction in LDL cholesterol for a reduction, you know, the amount of reduction in coronary heart disease event rate for a given reduction via PCSK9 is actually pretty modest. I mean, you don't see a lot of, that is, you don't see a lot of LDL cholesterol decrease. There's some, but there's a major decrease in coronary heart disease event rate. A small amount of LDL from day one seems to have a much bigger effect than the same reduction later in life. So there's a message, and the message is that if you do this early, you may be much more effective in preventing the disease than if you do the same thing later, same amount of reduction later. So there's a message, and I guess that the message is that go low and go early with LDL cholesterol, and we can have a major impact on this disease. Now, the question is, how much? I mean, can we really eliminate this disease? What kind of effect sizes can we have? Are we really looking at a 50 or 60 or 70 or more, you know, who knows, effect size? Are we really looking at 20 or 25%? 20 or 25% is interesting, but only a little. We'd almost stipulate to that. I don't think I'd do a big trial to show you that. But, you know, if we could essentially eliminate this disease, it would be a big deal. So that's the purpose of the ECAD trial. Won't dwell on it or its in tremendous detail, but the notion is to take people in their middle and early middle years who are healthy and basically treat a group of them, randomize them to either standard care or to standard care with the addition of a statin, basically using LDL. It wouldn't have to be a statin, by the way, but that's what's available and effective now. A few years from now, we may be using somewhat different drugs, not for sure, but basically treating the statins like you're supposed to treat a vitamin, except the difference is this is liable to be effective, and I'm not so sure the vitamins are. Okay, but it's a vitamin-like approach to reducing coronary heart disease and asking whether we can reduce death, MI, and revascularization. Can we reduce coronary heart disease event rate by lowering cholesterol relatively early in life? Okay, should it be at the age of 5 instead of 35? Maybe, but I suspect what we're going to see is a huge effect size in these people, and probably large inroads. But maybe I'm wrong, and that's why you do a trial. I wouldn't write a guideline today that says you ought to treat everybody with a statin, but I might be writing one in 5 or 10 years. Okay, so we think this is critically important science, and we think that the Peter Munk Center is in point of fact the perfect platform. I think Ontario and Toronto and the Peter Munk Center are in fact perfectly positioned to do something really big. If this works out, it's a big deal around the world. I want to pursue briefly just one other theme that relates to this business of prevention. If one looks at hypertension, it's extraordinarily important in stroke, not just in Canada or the United States or even Western Europe, but also in the developing world in a huge way. But only about half the people who are even treated well, who have access to really good medical care, which is a relatively small swath of the world, in fact gets adequate hypertension control. Now, we're seeing renal sympathetic denervation, okay, which is a transcatheter procedure involving the renal arteries, and you're going to apparently hear more about that tomorrow, being used to treat resistant hypertension. In point of fact, if one looks at the data, and I'm not going to take the time to go through it in any detail, but it would appear that a relatively simple catheter procedure is going to get simpler and simpler with the development of new balloons, in fact dramatically reduces blood pressure in a durable and safe way. Okay, that has yet to be fully vetted, but basically the initial data look that way. I think the step beyond that is to turn around and say, fine, what about using this as a durable way to treat essential hypertension? Gets rid of all the drug side effects, gets rid of all the compliance problems, gets rid of the cost of drugs over time. Could be a huge, huge thing in terms of prevention. And there, I think the emphasis is on stroke prevention, but treating, I don't think I need a major advertisement for the importance of treating high blood pressure, and this may be a way of doing it. It's kind of the step beyond the next step. But once again, this is something that we have some interest in. Mike Farquhar and I have spent a fair amount of time discussing this. And we have a trial that we'd like to propose. We even have an acronym for it, which I think is the key thing in getting a trial going, is you may not have the science down, but by golly, you got to have a decent acronym. And SOAP strikes me as that in a substantial fashion. So what's the conclusion to this? We actually have covered a lot of ground. What's the role for family practitioners in research? Well, I think it's the same as the role for physicians in research. I can't have a lot of trouble drawing a bright line between saying, well, this is the role of cardiologists, and this is the role of internists, and this is the role of endocrinologists. But they're clear, obviously there's a role, and you have some advantages. You really see the spectrum of disease, and you see it in real people. I do think there may be a practical available approach to eliminating coronary artery disease, and we really want to prove it. And I think we may also have a practical available effective way of providing durable hypertension control. And so, it's an exciting era, and I'm telling you, you guys are poised with this Peter Munk Center. You've got the machinery in place to really do some big things. So I thank you for letting me be part of your organization here today.
Thank you, Mike, for that inspiration. And, I think that we're always trying to push the envelope here. We're dealing with a huge epidemic, and we need to always find ways to curb that. So thank you, Michael. We'll hopefully have some interesting questions for you at the end. We'll now ask Vicky LeBlanc to come forward. Vicky is a psychologist who is really making a lot of headway in the research into the effects of stress on performance and health. She's cross-appointed at in the Faculty of Dentistry, the Faculty of Medicine, and the Faculty of Social Work at University of Toronto. So Vicky's here. Vicky, welcome. Thank you very much for coming.
So thank you for inviting me to speak to you today. So I'm going to start with a caveat that I'm not a physician and I'm not a cardiologist. My disclosure is that I'm a slightly twisted individual because I spend my life trying to stress people out and see what happens to them, and I quite enjoy what it is that I do. So what that means about my psyche, I'm not sure. So what I want to talk to you today is from a psychosocial perspective and looking at what do we know about the relationship between stress and cardiovascular health. And I'll start with also another caveat is that the research is fairly messy because we have a fairly good idea that there's a strong association. We're starting to get an idea of what the mechanisms are, but we're still really doing a lot of inroads and trying to understand it. So what I'm going to do is mostly tell you a story and how the patterns that are starting to come out in the literature are telling us. But I'm not going to put up a lot of numbers. I'm not going to put a lot of data because I think that'll just confuse you more than anything else. But I'm happy to answer any questions if you want me to point you to the specific literature. So in the past couple of decades, as a society and as researchers, we've become a lot more interested in terms of what the role is that stress plays in our lives. Whether it is that you believe that we actually live in a more stressful society or just that we become more interested and more aware of the role that stress can play, it's become much more of a topic of research. And we're spending a lot of time trying to understand what is the role that stress plays, especially chronic stress plays in mental health, such as sort of endpoints as depression, anxiety, burnout. What role it plays in immunity in terms of making us less resistant to some of the bacteria or viruses that we encounter. And also within the context of this presentation is what is the role that acute stress and chronic stress is going to have on cardiovascular health. One of the reasons that the interest came into looking at what is the role of stress is that a lot of the research around the turn of the century started recognizing that primary and secondary risk factors didn't fully explain or account for cardiovascular disease and events. So the big ones that we know, such as smoking, hypertension, diet, physical activity, we knew that these are important players, but they don't fully explain it. And there was a lot of epidemiological research that was showing that people from low socioeconomic status, even when we controlled for all of these lifestyle issues, still had higher incidence of cardiovascular disease and cardiovascular events. So that got people interested. Well, we know that low socioeconomic status leads to higher chronic stress, and it's a more difficult life. What is the role that it has? Is there actually a link that there is with cardiovascular health? And we started seeing a lot of epidemiological research that looked at links and found some associations between high stress levels and cardiovascular health. So for example, for individuals who have high job strain, especially those individuals who have jobs that are high demand but low control or low rewards, what we find is generally the literature tells us that there's a 2 to 4-fold increase in the risk of cardiovascular death in these individuals. We know that from the literature, from epidemiological literature on bereavement, so what sometimes is known as sort of the broken heart syndrome, is that within the first month of a significant bereavement of the death of a loved one, we're going to see about a 2 to 3-fold increase in cardiovascular mortality within the first month, and usually after about 2 to 3 months, the risks go back to what it is in the normal population. And in terms of disasters, there's been a lot of epidemiological research that's looked at when we have major disasters that are creating sort of a lot of population-based stress, we see increases in the number of cardiac events. So for example, the 1994 earthquake that was in Los Angeles saw approximately a 6-fold increase in sudden cardiac deaths. So whereas in the weeks previous to the earthquake, the average number of sudden deaths were about 4.6 per day in the weeks previous to it, the day of the earthquake, they saw 24 cardiac deaths. And we see some similar results with sort of the first day of bombing of the 1991 Gulf War. We see some similar data coming out of research that's looked at sort of the major earthquakes that have happened in Asia. And these relationships are found even when they control for lifestyle issues, even when they control for the presence of environmental or physical trauma to the individuals. So what that suggests, this kind of epidemiological research suggests that there is an association between stress, between high levels of stress and cardiovascular health. What that research doesn't tell us, it doesn't tell us by what mechanism that happens. Are they just two things that happen to occur at the same time? Or is there actually a role for stress in cardiovascular health? So in order to really be able to understand what that relationship is, it's very important for us to be able to understand what is stress. And the reason that I say that is if I ask 10 people in this room what is stress, I'm going to get 10 different definitions. That's one of the challenges that we encounter when we try to study stress, because it's such a ubiquitous term, and we're all very familiar with the experience of it. But in terms of trying to operationalize it for the purposes of research, it can be very difficult. And so the first thing that I want to do is talk more about, from the stress world, what it is that we mean when we're talking about stress. So the first component, or the essential component that there is for saying that somebody is stressed, is that there has to be an environmental element to it. This is what we call stressors. They can either be acute stressors, so these are brief events. They often come with an abrupt onset. They can be unpredictable, they can be uncontrollable. So one of them can be public speaking, it can be examinations, it can be a disagreement that we're having with somebody, it can be a fender bender. They're usually very short duration. We sometimes don't see them coming, sometimes we do see them coming, but we can't predict how they're going to turn out, and we can't control what their outcome is going to be. There's also, from a different, and these function in a different way, are the chronic stressors. So these are things that are persistent conditions, and most often they're going to be associated with our occupation, with our social relationships, or our broader environment. And they can be divided in two. So they can be major life events. So the dissolution of a marriage can be considered a chronic stressor or a marital strain, or bereavement can be a major life event. But they can also be daily hassles. So the work conditions, if you have a strained work environment, if you have constant disagreements that you have with your coworkers, they can be of both natures, and these are going to be chronic stressors. However, the environmental elements are not the only key point, is that the individual is an important interaction that comes in, because not everybody's going to react to those different kind of environmental situations, environmental stressors, the same way. And it's going to be very strongly, stress very strongly depends on the individual appraisal. So basically how a person reacts to it. And the strongest sort of theoretical perspective that we have about stress is that if, as an individual, I'm faced with something that challenges a very important goal that I have, so that I have to have some stakes in it, I'm first going to look at, say, what are the demands that are being placed on me in order to still be able to accomplish my goal? Once I do that, I say, well, what are the resources either that I have within me or within my environment in order to be able to meet those resources? If I think that I have the resources to meet the demands, then what's going to happen is what we call sort of a challenge situation. We're going to mobilize some energy. We're going to have to sort of get up and go and deal with it. But it's not going to be threatening. We're not going to be challenged. So this is, athletes call this being psyched. It's, you know, sometimes it's what we strive for. We look to be challenged in our role, but we think we can manage the demands that are there. We define stress as when we feel that we don't have the resources to meet those demands, and this is what we call distress. When people encounter this kind of distress, there's a very specific pattern of responses that happens. The first is going to be the subjective, and the one that we're very familiar with. So there's going to be the emotional component. There's going to be worry, anxiety, anger, irritability. There's that feeling of being stressed. We're going to have some altered cognitive processes. So, for example, our ability to remember things is going to be impaired. Our ability to pay attention to things is going to be biased to that source of stress. And in the long term, we know that that can lead to depression, to burnout, and to anxiety. But there's also a very specific physiological pattern that we have when we have that distress. And one of them is going to be an endocrine. We see the activation of the hypothalamic pituitary adrenal axis, which leads to the release of cortisol. And then we also see some cardiovascular, so sympathetic nervous system activation. And these are the ones that researchers have been looking to see how these may function in order to create, or how they're linked with cardiovascular health. So the activation of the HPA, as I mentioned, is going to lead to cortisol secretion. Now, cortisol secretion is a hormone that the role that it plays in us is sort of a get-up-and-go hormone. It allows us to sort of mobilize energy in order to face a threat that we have. So it's going to mobilize glucose, it's going to mobilize free fatty acids, it's going to decrease functions that are not necessary in that moment. So it's going to decrease growth and sex hormones, it's going to temper the immune system, and it's going to increase cardiac output and blood pressure. So this is a very adaptive response for organisms to have when you're faced with a threat and you have to mobilize energy and you have to try to accomplish a goal that is that you have. The problem is that when we have these chronic cortisol elevations, what we see is we start seeing some dysregulation, we start seeing damage to the system. And these dysregulation, and this is where the literature is still working on understanding the mechanisms, but what we know from research with animals and research with some research with humans, but primarily animal-based research, is that chronic cortisol elevations are going to lead to, they're associated with metabolic syndrome, so that the resistance to insulin and central obesity. And they also, elevated cortisol levels also seem to lead to accelerated atherosclerosis. And to give you an example of the relationship that we found in human relationship, some researchers, a paper that just came out 2 years ago, looked at approximately 900 participants. They're around, the minimum age was 65 years of age or older, and they followed them for 6 years. And what they looked at is that at baseline, they measured what their 24-hour urinary cortisol output was, which in the stress literature is considered a good marker of chronic stress levels of individuals. They did a medical evaluation to know what their health was, see what the presence was of cardiovascular disease or not, and other health indicators. They did health visits 3 and 6 years follow-up, and then they also followed all the death certificates to see what the causes of death had been of the people who had participated in the study. What they found was a very strong relationship between baseline urinary cortisol and the increased risk of mortality. And what they found is that the people who at baseline had the highest tertile, so the top 33% in terms of urinary cortisol output, had 5 times the risk of dying of cardiovascular disease compared to the people that were in the lower third. And what they found also is that there was no association with dying from non-cardiovascular disease. And so the question is, well, did most of these people have cardiovascular disease? They did do a sub-analysis, and what they found, while the risk was greater for people who did have a cardiovascular disease at baseline, they still found that significant association between those baseline cortisol levels and cardiovascular death in people who didn't have any indication of cardiovascular disease at baseline. So this is starting to suggest that the elevated cortisol levels that we see in chronic stressed individuals do have a relationship and may play a role in leading to decreased cardiovascular health. The other physiological variable that we see when people are having stress responses is that we see alterations in the sympathetic nervous system. One of the most constant responses is that there's going to be increases in systolic and diastolic arterial pressure. And we're also seeing an altered heart rate and altered heart rate variability. And the reason that I put altered is that we still don't quite understand what the role is that stress plays on heart rate and heart rate variability, because depending at the time in which we measure it, and the time between the stressor and the time that we measure it and the type of stressor, we're sometimes going to see increases, sometimes we're going to see decreases. So this is one place where there's a lot of research trying to look at what is the exact effect of stressors, different kind of stressors, on the heart rate function. But what the research does tell us is that chronic elevations and chronic alterations of the sympathetic nervous system is going to lead to the development of atherosclerosis. And the other thing that we also know from research, especially with animal research, is that in individuals who are vulnerable, acute stressors and those disruptions of the sympathetic nervous system is going to lead to plaque disruption and thrombus. So you're much more likely to have a sudden cardiac event in people who have acute stress responses. But one of the interesting things that's coming out from this research is the idea of stress reactivity. So it's not everybody who's exposed to stress. It's not everybody who has some stress response who seems to be at risk. There's a certain 2 groups that tend to be more susceptible, and this is what we call the hot responders and the ruminators. So the hot responders are the people who, in the face of a similar event, are going to be having a greater physiological response than other individuals. And the ruminators are the ones, when we talk about ruminating, is after we've been through a stressful event, some individuals are going to be able to sort of come back to baseline and be able to go back normal. But as human beings, we engage in this rumination. We kind of carry it in our mind, we turn it around, we worry about it, we chew on it for a while after we've had a stress. And the literature suggests that the people who tend to ruminate are the ones who are going to have a more sustained physiological stress response and who are going to be more at risk. So a really good meta-analysis of this was a study that just came out that they did a meta-analysis of 36 articles that had actually looked at this, where they specifically controlled in the laboratory, they exposed people to mental stressors, so either public speaking or a number of different tasks that we know are going to create sort of social stress for individuals. They measured what their cardiovascular response was to those situations. Most of the literature looked at heart rate variability, heart rate increase, or changes in blood pressure. And then they followed them for various periods of time to see what the future cardiovascular health status was going to be. And what they found is that fairly consistently there was an association that came out that those individuals who had a greater stress response reactivity to those mental stressors in the long run, had poor cardiovascular risk status, and the most common associations were with incident hypertension and also higher systolic and diastolic blood pressure. So those people who have a stronger sympathetic nervous system response to stressors are more likely to be less healthy in the longer run. And those ruminators, so those people who have poor stress recovery, so after the end of a stressor, they maintain that elevation in stress responses. Again, they found that these people are more likely to have an impaired cardiovascular risk status. They're going to have greater carotid wall thickness, and they're also going to have the higher systolic and diastolic blood pressure. So the implications from this, from a prevention perspective, evidently, thank you. So one of the implications from this is the individuals who are at risk for elevated stress responses also seem to be at risk for impaired cardiovascular health. So from a prevention perspective, what that tells us is if we're able to identify those individuals who are more likely to have a greater stress response or to have a sort of maintained stress response to the events of their lives, if we can identify these individuals and devise appropriate prevention approaches, we might be able to help improve what their cardiovascular health is going to be. So this is where my research group comes in, because we're very interested in saying who gets stressed. And one of the areas that we've been looking at quite a lot is looking at coping styles. So now coping styles are a theoretical construct. Well, what they are is when a person encounters a situation for which they feel they don't have the resources to meet it, there's some habitual ways that they're going to deal with that to approach the problem. And there's different definitions, but they tend to be divided into sort of these three categories. So the first one is going to be problem-oriented. So problem-oriented is that you're changing the nature of the task. So given that we're winter, the example that I always give is that I'm not a very good skier, but my husband drags me to go skiing every winter. And you always start out very well, and then towards the end of the afternoon, you notice that hill starts to be a little bit steeper, and your muscles aren't holding you up as much. And so you start being a lot more nervous because it seems to be like a much more daunting. And that last run always seems to be the one that's dangerous, and that last run is always the one where people also get injured. Now, if I'm problem-oriented, what I'm going to do is I'm going to change the nature of that problem. So if I think that the hill is too steep, what I do is I start going side to side. So I'm actually changing the nature of the problem. If I'm emotion-oriented, what I'm doing is I'm focusing on the emotions that the situation is creating for me. So as I'm going down the hill, I'm focusing on the fact that I'm feeling stressed, and I'm very aware of the fact that I'm stressed, and I'm paying attention to my somatic symptoms, I'm paying attention to the fact that I'm worrying, I'm telling myself I shouldn't be there because I'm not prepared for that. If I'm an avoidant-oriented, what I'm doing is I'm avoiding it. And for any of you that can notice my tan, what I do is I go sailing every winter rather than go skiing, which what it does is that avoids you from having to deal with the situation. The problem with being avoidant is that when you are faced with that problem, it's not going to teach you what the skills to do it. And we know that looking at subjective stress, that problem-oriented and emotion-oriented can both be beneficial when people are being in a subjective stressful situation, and avoidance seems to have some mixed results. And what we are interested in looking at is how can these predict the physiological responses that people are going to have? So the general design that we do in our research is we're very interested in who's going to get stressed. We're very focused on frontline workers. We're interested in those people who habitually experience acutely stressful and chronic stressors as part of their lives. So police recruits, paramedics, child welfare workers, and police communicators. And our general research design, what we do is we expose them to stressful situations. We create very elaborate simulations that we know are going to create stress for them. And ahead of time, we look at their demographics and we measure a number of different things. In this case, we measure what their coping styles are, what their habitual coping styles are. And then we expose them to an acute stressor. So for example, for the paramedics, we put them in a simulated land ambulance where they have to do a cardiac resuscitation, and we impose a lot of different sort of social evaluative and noise stressors that we know are fairly assured to be able to create stress, and we look to see, do any of these demographics or coping styles that we measure predict who's going to have a subjective and a physiological stress response to these situations? So I'll just show you the results that we have from two studies. So this is a study that we did with police recruits that were, again, put in a simulated scenario. So that task, remember, that's the problem-oriented, is sort of breaking down the nature of the task and working at it. We found that it had no relationship with their anxiety or the strength of their cortisol or heart rate response to this scenario. However, those who are emotion-oriented, who focus more on the worry and the emotions that they have, we found that subjectively they don't necessarily have a greater response, but they have a greater cortisol response and they have a greater heart rate response to that scenario. But the one that really troubled us is the ones who are the avoidant copers, the one who tend to focus more on distractions and avoiding the sources of stress. They report being less anxious. They tell us subjectively that they feel less anxious about it, but physiologically they're still mounting a physiological response to that situation. And when we did a similar study with the paramedics, in this case we didn't look at the heart rate responses, we just looked at anxiety and cortisol, we found a somewhat similar pattern that in this case task-oriented did help reduce their subjective anxiety. Emotion-oriented made them have some more anxiety, but again, those avoidant copers are the ones that sort of puzzles us because they don't have a greater anxiety response, but physiologically they're still mounting a response. So it's probably a defense mechanism or sort of an adaptive mechanism that they do because these are frontline responders. If they can sort of subdue and reduce that emotional response that they have, there's the perception that they're going to be able to do their work better. This is what they call sort of the detached concern. The problem that happens is that subjectively they may not feel they're having the anxiety, but physiologically there's sort of that silent response that they're having. So what that research suggests is that we know that coping styles, from the literature that's coming out, is that coping styles do seem to be able to predict the subjective and physiological stress responses, at least in frontline workers who are having to deal with work-related stressors. So it leads to the idea that preventative approaches that target management of emotional triggers and that are focused on coping styles may be a promising way to be able to have a preventative approach to cardiovascular health. And there's some research that shows, and there has been some research that has looked at if we do these kinds of approaches and we do behavior modifications or we do stress management training, can we improve cardiovascular indices? And the research is actually quite mixed in that. But what seems to be coming out now is that one of the problems is that a lot of those studies are not actually able to reduce indicators of stress. So the fact that they're not having an effect on cardiovascular health may be because they're not reducing stress. But those studies that do succeed in reducing the stress levels in individuals do seem to also be associated with greater sort of cardiovascular indices. And one of the issues that's with that is, remember what I told you about the stress, is that not everybody responds to the same stressors and not everybody deals with the same stressors the same way. So one of the challenges with stress management is it has to be very individualized, and the individual has to, as a clinician or a mental health professional, identify what is the source of the stressor for an individual, how do they respond to it, and a lot of training has to be individualized to the individual. So a lot of sort of trials that are attempting sort of a one-size-fits-all may be limited in their ability to sort of do systematic reductions in stress. So just to conclude, in terms of, this is sort of an overview of where it is that we're going in terms of the relationship between stress and cardiovascular health, is that the literature is going in the direction, the research seems to be suggesting that stress seems to be a significant factor for cardiovascular mortality. Some studies have even said that the risk factor may be as great as some of the big ones as smoking and diet. And the research now is at the point of trying to understand the mechanisms by which these cortisol responses and these sympathetic nervous system responses, and especially at the chronic level, by what is the physiology and the mechanisms by which they actually lead to decreased cardiovascular mortality. The implications from a clinical perspective is that this suggests that we have to be able to pay attention to screening for psychosocial risk, especially for screening for people who have high stress in their lives, but not just the ones who have a lot of stress in their lives, but the ones who respond to it strongly. So the ones who are sort of the hot responders, or the ones who tend to ruminate and carry the stress with them. And also, we're faced with the problem of those avoiders. So people who may report that they don't have stress and may report that, yeah, they have a lot of stresses in their life, but they're doing fine, but physiologically they're still having a response. Because this could be a silent risk that's a little bit difficult to identify. And once we identify them, there are possible approaches that can be done. The challenge is that they often have to be done at the individual level. But there are a lot of research looking from sort of behavioral interventions, very simple, straightforward cognitive behavioral approaches that focus both on relaxation and stress management in terms of reframing and coping, that are successful in reducing subjective stress. And so we'll do some research looking at, if we do these and we individualize them, can we actually improve cardiovascular health? and also be able to sort of be closely linked with mental health specialists, so that if patients come into an office and are at high risk for it, family physician visits can often be very short. It can be very difficult to do the kind of psychosocial approaches that need to be done. So developing a really good relationship with mental health specialists who actually have the training, are able to do that, might be able to be a very preventative and possibly very effective preventative approach to decreasing cardiovascular mortality. So I'd like to thank you for your time, and I've included my email in case anybody would like to get the references of the literature that I'm quoting, or get some more information. So thank you.
Thank you, Vicki. Those are very important recommendations. I think our patients suffer from so much stress in this day and age that we all should be paying attention to that in terms of our preventative and health promotion policies. So we'll have a chance to question with Vicki, send some questions your way, Vicki, after the next segment. We'll end this health promotion segment last but not least with Paul O. Paul is the Medical Director of Cardiac Rehab and the Secondary Prevention Program at Toronto Rehabilitation Institute, which we're proud to say is now part of the University Health Network and a key partner with us here at Peter Munk Center. Paul has really, I think I can say, a triple threat. He's practicing, he's teaching, and teaching so many different kinds of folks too, not just physicians, but people across the spectrum of healthcare delivery. And we're getting involved in research together. So Paul, welcome.
Thank you, Mike. It is indeed a pleasure to be here. Woohoo! We hope that you'll all be excited as part of this. So we're pleased to be part of the Peter Munk family. And I'm here also representing that we've got a partnered rehab program at the Toronto Western site. Collectively, I think we represent the largest program in North America, and want to be a resource to all the folks in the room. And it's nice to see friendly faces in the room and reconnect with some individuals. My disclosures that I do serve on some advisory boards. We hold research funding from a number of different organizations. And of course, I have professional affiliations. And I'm here to sell you the concept of exercise and physical activity and why that is so important. And I get 25 minutes on the platform to do so. So follow me in this journey. That I would like to spend some time with you talking about this thing called exercise and physical activity that we spent zero time in during our medical curricula, right? That there was no opportunity in medical school to actually talk about this. But I would argue, and I hope that you'll take away from this, that this is the unrecognized vital sign that, of course, trumps everything else. What Dr. Domanski said, what Dr. LeBlanc says, this is the real goods. This is the most important thing. There's a dose response that I want to share with you about why this is so critical. We'll talk about fitness values, and I hope the dual layer that you'll take from this is good for your patients. It's also good for you. Scanning the room, this is a very healthy looking audience, such a good looking audience, in fact. And I know you're fit and active, but sometimes there are opportunities for us to even think about this even more. So reflect on fitness values, reflect on what we can do, and it makes it even better than when we come to rehab programming or exercise programming of how we convey that information. And I'm always interested in looking for enhanced collaboration. What a great time. Dr. Domanski kind of set the stage for us with prevention and why this is so important. And you may have been aware that the World Health Organization held a summit in New York in September. And this was meant to be a pivotal moment in the WHO's history. I don't know how many people actually heard of this. No, which is a tragedy. But the recognition from the WHO, obviously wonderful, important. We've had a focus on infectious diseases for many years and have made great strides. The recognition from WHO is that the biggest killer, as Dr. Domanski said, of people around the world, developed and developing and underdeveloped nations, is chronic illness. Cardiovascular disease, respiratory disease, cancer. 60% of all deaths in the world today will be attributable to these chronic conditions. The price tag in terms of healthcare spending for the next 10 years is $35 trillion worldwide. So some opportunities to impact on prevention is so critical, and it's in all of our hands, right? This is a collective solution. So WHO for the first time has posted things like global recommendations for physical activity, recognizing that this is really, really important. And it comes down to some very, very simple things. And the challenge for us in this technology world, where technologies are so important, but there are some simple things. If we can do simple things, but do them really, really well, we can make a huge impact. If we can think about smoking, having the right amount of alcohol, maybe the right kinds of alcohol as well, limiting salt and trans fats and eliminating trans fats, diet and physical activity. This is felt to be the platform that will really revolutionize health around the world. Okay, that's our preamble. That justifies why I get 20 minutes on the platform now. So let's ask a question. Let's do a little bit of exercise motivation. Let's do a little bit of voting with your arms. So if we had to ask you, what proportion of cardiovascular risk, or indeed chronic disease risk, can be attributed to lifestyle-related factors? Less than 25, 25 to 50, 50 to 75, or greater than 75, vote with me. Only 3 people voted. You want to do that again? Greater than 75%, I won't bias the audience. Yes, thank you very much. So if that's true, if that much of disease can be attributed to lifestyle factors, how much of our time do we spend addressing those lifestyle factors? Interesting reflection. If we look at some data, look at Interheart, for instance. Now, we don't want to talk about those people in Hamilton, in Toronto, but those folks in Hamilton do some good research sometimes. An Interheart study that everyone knows from a few years ago talked about global risk factors for myocardial infarction, and it didn't matter where you lived in the world. It all had the same face to it, kind of affirming what the WHO said. And 90% of our risk for myocardial infarction, in the primary sense, can be explained by these 9 risk factors that include things like obesity, cholesterol, whether we get enough fruit and vegetables per day, diabetes, hypertension, physical inactivity, having the right amount of alcohol consumption, smoking, and stress, to Dr. LeBlanc's point. So these are the basket of goods that really drive risk. Nothing fancy here, but good motherhood kinds of issues that have a big impact. If we think of medical cohorts, and of course the captive medical cohorts over time in the States, the Nurses' Health Study of 70,000 nurses for the last few decades, the Health Professional Study for the men, you can see that there's a graded relationship of risk on the y-axis versus number of risk factors on the x-axis. The more healthy behaviors that you have that include not smoking, eating well, being active, controlling weight, having the right amount of alcohol, there's a lovely graded response. The more healthy behaviors you are, the less heart disease or stroke that you will have over time. Thinking about physical activity now, narrowing down. How many minutes are needed? How much is enough? The corollary in your practice, how many minutes, what do you ask of your patients? In your vital sign things, you ask about blood sugar and blood pressure and have really good numbers for there. When you ask about exercise, what do you quantify as the right amount for any individual? So, how many minutes are needed to reduce cardiovascular risk? Less than 100, I want you to vote again. Less than 100, 100 to 200, 200 to 300, greater than 300. And the good one about here is that everyone is right, but some of you are more right than others. If you look at this complex graph that was published in Circulation from just a little while ago, so again, on the y-axis is relative risk of heart disease. On the x-axis is a quantification of physical activity. In this case, it's kilocalories per week, and I'll give you the time equivalents for this. But you see there is a curvilinear response, that the more activity you do, you tend to reduce the amount of risk of heart disease. And I'll show you some key numbers here. So 75 minutes of moderate activity. This is walking at a vigorous pace, so you're just a little bit short of breath, a little bit sweaty. This isn't running full out on the treadmill and getting all drenched in sweat. This is just moderate walking. 75 minutes will give you about a 9% reduction in cardiovascular risk. Go up to 150 minutes, you'll get about a 14% risk reduction, and out to 300 minutes per week, about a 20% risk reduction. So you get benefits at whatever level, you'll get a little bit more. The bad thing that came out from this study was the headline in the paper that said, New study shows you don't have to do a whole lot. 15 minutes is enough, which is not the answer that we wanted from this study. It says that there is a graded relationship. 15 minutes is a good start, but you can get more. And if you get out to this 300-minute level, the curve kind of flattens out there. So we'll remember that as a dose-response target when we think about heart patients. So one more look with another chronic disease, looking at people with, say, with diabetes. And this is again from Nurses' Heart Study, or Nurses' Health Study. Those nurses who had diabetes, about 5,000 of them who've been followed over time, risk of heart disease on the y-axis. On the x-axis this time is the number of hours of vigorous exercise per week. Doing less than 1, doing 2 to 3 is the yellow, 4, and then greater than 7 in the green bars. You'll see once you get out to about 4 to 5 hours, or about 300 minutes of exercise per week, you can cut your chance of heart disease by about 50%. Okay, so think of that as the dose, about 300 minutes per week. And for the cardiology-minded individuals in the audience, some other neat experiments. So it's all about the coronary arteries for some individuals. So a bunch of Germans, Hambrecht and Niebauer, we had Joseph Niebauer out to our program a couple of years ago. He talked about this experiment. You find about 100 men, German men, who undergo angiography and they're shown to have heart disease, about 60, 70% stenoses. Randomize them to different levels of activity and then follow up with angiography a year later. So those who do a program of about 150 minutes with 30 minutes a day of exercise per week kind of stabilize. Exercise is good. Those who do less than that, though, on follow-up angio, they progress with their coronary lesions and they earn themselves a stent and other wonderful things. The neat part, though, is if you take these guys and do some higher levels of activity with them, and in Germany, of course, they cycle, and they played soccer together with the cardiologist on a daily basis. And the follow-up angio showed that you can actually regress lesions over time. And we use this slide with our patients all the time. This is the fun thing. The dose does matter, and dose can actually be really, really important. And Dr. Domanski already said that stents are an important adjunct, but they don't cure necessarily. And if we think of the miles and miles of arteries that people have, what's our treatment for them? Lowering LDL, managing stress, taking our ACE inhibitors, physical activity would be another wonderful part of that equation to actually clean out some of these arteries. So there is a distinction. While activity is important, again, this slide shows you that risk of heart disease on the y-axis, and in this case, on the x-axis, is percentiles of physical activity or aerobic capacity. The gray bars, first of all, show that if you get more physical activity in, there's a clear relationship in reducing heart disease. But even better, if you can jack up aerobic capacity or fitness, the relationship is even steeper. So do more, but do more with enough intensity so you actually get fit. And that's how you prevent heart disease. So it's important for us when we give information, go get active, Mr. Smith. But here, I want you to get active in this way that's going to actually modify your fitness levels. Get up to a certain level. So that's what we're going to talk about next. So this concept of fitness, again, in med school, we didn't get this. I think it's a really important concept. When I get a chance in front of any audience, I get real excited. And let's talk about fitness. Here's the most important physiologic relationship in the body, at least for the next 10 minutes. So the purpose of our lungs is simply to move oxygen. That's all it does, to the heart, and the only purpose of the heart is to pump it. Pump it where? To the muscle, down to the level of exercising muscle, and down to the level of the mitochondria. Remember, we got those things called Krebs cycles and those sorts of things, the purpose of which is to generate ATP. ATP gives us energy and we can go. This is what's important to patients. Who knew? We can train our mitochondria. This is the purpose of exercise, that we can actually, at a cellular level, adapt, get fit, get strong, and move, so we can carry out ADLs or we can exercise and do other good things. We produce carbon dioxide as the byproduct and comes back out. VO2, mathematically, is oxygen delivery times extraction. This is how we can actually quantify fitness levels. Why is it important? And this is how we can actually do it in the lab. So up at our lab at the Rumsey site up at Bayview and Eglinton, or indeed at the labs at UHN, we can also measure these things. So we can directly measure fitness. And we do this with our patients on a regular basis. We can do it with you as well. And some of you have actually come to our labs to get assessed, see how fit you are. How fit are you? There's some rough mathematical approximations, and the equations look like this. So if you're a woman in the audience, 48 minus 0.37 times your age, or if you're a male, 60 minus 0.55 times your age. And if you look at those numbers, I've done the calculations for you. So if you're a 40-year-old woman in the audience, your VO2 or fitness level should be about 33, and if you're a male, it should be around 38. Okay, so what's the deal? What's the deal with this and the typical heart patient? So the typical cardiac patient is about 62, is usually a male, and has coronary artery disease. What is their fitness level? Why is this such a big deal? Vote again. What is their fitness level? Given that yours is around 35 or 40, what's the cardiac patient's fitness level? 5 to 10, 10 to 15, 15 to 20, greater than 20. Most of you didn't vote again. Thank you to those who did participate. And the answer is the typical person comes in with a fitness level about 17.5 mils per kilo per minute. They're about 65% of their age predicted norm. Why is that important? This is a risk factor. It would be like saying that the typical person coming in with cardiac disease has a blood pressure that's about 30% higher, so 180 over 110. And that's their blood pressure. Good. Good, let's just leave them there. And you would never leave them there, right? But if I told you there's another risk factor on the table, a fitness impairment of 35%, and that's completely modifiable, by the way, would you do something about that? And the answer should be yes. 65% is where they live. It's no wonder people feel fatigued. No wonder that they can't do their ADLs, that they feel short of breath trying to shop. We think it's their heart disease, we think it's their age, we think it's their comorbidity. Part of it is just they're just unfit. And this can actually be changed. So, how do you do it? If you sign up for the gym, who signed up for a gym in January? So if you sign up for the gym and you meet the trainer, they're going to tell you, okay, I've got this wonderful scientific program for you. I'm going to put you through cardio training, and I want to do some assessment with you first of all, so of course. Then I'll put you through cardio training, and I want you to come here 3 times a week, maybe even 5 times a week, and I want you to put you through a weight circuit. Okay, so that's great. That's tried and true, because we've been doing that for thousands and thousands of years, and that actually works. For the heart patient, we should do exactly the same thing. We might need to be a little bit more careful up front. We might need an ECG. We might need to do a stress test to make sure you don't have arrhythmia. You don't have ischemia. You're not going to drop dead while you're doing exercise. But let's do cardio. Let's do resistance training. Most importantly, let's do it and repeat, and repeat, and repeat. And if you do that, that actually works extremely well. Here's an example of 9,000 patients worth of data from our program that people start off doing aerobic training, 1.5 miles in about 25 minutes. They do that 5 days per week. We see them every week or 2 and then build that up. So by the end of 9 months, they are doing about 3.5 miles. They're out to about 50 or 60 minutes of exercise per day, 5 days a week, equals 300 minutes of exercise per week. And if you think back to those coronary arteries, that's the thing that's going to affect those coronary arteries. It actually makes sense. So we got dose response going on here. And then if we think of the fitness equation, 65% now becomes virtually normalized by 12 months. Oh, by the way, this is an important kind of threshold because people live with a VO2 that is very close to levels where it's difficult to live on their own. So those of you who are familiar with transplants, for instance, a transplant, to qualify for a heart transplant, your VO2 level is 15 or below. This one of the strongest predictor of whether your elderly will end up in a nursing home over the next 10 years after age and comorbidity is a fitness level less than 15. The typical cardiac patient is about just above that level. The typical person living in the community with stroke has a VO2 of about 13. No wonder they're tired, and we say it's because you've got a neurologic disability. In fact, it's because no one's ever exercised them. It can change, and this shows you, with 9,000 people worth of data, you can change this completely. Why else is important? What else is going on with the fitness paradigm? That if you look at survival now, fitness predicts survival. Darwin was right, that this is survival of the fittest. And for the cardiac patient, the low curve there shows that if your fitness level is low, less than 15, your mortality curve is a whole lot steeper than if you've got, than if you've got a high VO2, less than 22. Okay? So this is real people, real data. Fitness is important. Overall, if you look at the cardiac rehab literature and the soapbox that I get on, there's good evidence that we can actually reduce mortality with the things we do. We need to do more of it. In fact, we can lower mortality by 20%. So there's another thing that goes on with a behavioral sort of construct as well. And the more you do, the better off you're going to be. And in the US Medicare environment, they've got a very well-circumscribed rehab program. You come for 12 weeks, you come 3 times a week, and so you get 36 visits. If you simply do this analysis, neat analysis that was published in Circulation, so a full program is 36 weeks, and if you compare that to people who only do 2/3 of the program, 24 visits, or 12 visits, 1/3 of the program versus 1 of the 36 visits, there's a very striking mortality gradient here. So the more you do, the more physical activity you'll get in, the fitter you'll get, the better you're going to survive is the outcome from this. So that's what's at stake here. Leads me to the next part of things, and we've also done an analysis at UHN of this sort of data. So this represents the survival curve again, y-axis. On the x-axis is the number of days from the event. So this is over 5 years of time, people with heart disease. The blue line are people living in Ontario with heart disease after surgery, after angioplasty, after myocardial infarction, who don't do rehab. The pink line are those who are the same people, a match for age and socioeconomic status and all risk factors, who do rehab. The mortality gradient is 50%. So this is what's on the table for us to act on today, tomorrow, next time you see a patient. Are you getting enough? So we've had a little bit of silo in our system. We're looking to integrate, and this symposium is one example where we integrate much, much more closely. We look for programs that we can do together, and prevention is one great example of that. So the reflective question, now that we've talked about evidence, we've talked about dose response, we've talked about why this is important, of the last 100 people that you saw who have heart disease in your practice, how many went through a rehabilitation program, or how many did you counsel on a structured exercise program and they did it? Vote again. Well, maybe you don't want to vote again. Maybe this is a reflective one. Is it less than 25? Is it 25 to 50? Is it 50 to 75? Is it greater than 75? I can also ask you, what should it be? And it should be greater than 75. I can tell you the answer across Ontario and across Canada and across North America and across Europe. The answer is about 25%. So if I said the same thing, and so people get lost, 25, 30%. People get lost in the system, right? And again, the plea for integration is that we can do a better job at building seamless cardiovascular care across the continuum, involving all of our partners and using all of our strengths to do so. I'm actually a pharmacologist. What the heck why am I on the stage doing this thing? Because I think there's lots of analogies with medicine. And we've done very well with medicines. After your heart attack, we'll give you an aspirin. And we're very good about that. We don't say, here's some aspirin, take some. Good luck. But that might have been the standard for our exercise programming. I'd like you to get active. Let's discuss it in 6 months. And no wonder when they come back that they haven't moved very far. We're pretty specific with aspirin, aren't we? Take one every day and repeat. Oh, and by the way, if you have problems, if your stomach's upset, take it with some food. And here's a helpful reminder that if you have trouble remembering, take it in the morning, put it beside your toothbrush, and you'll take it with you. And we give all of those really cool clues. Exercise. I want you to start with 10 minutes a day. And I want you to do it at an easy pace. I want you to get started. I want you to repeat that 5 days per week. When I next see you, we'll talk about how you've done. And let's increase that by 5 more and 5 more until we get to a level where it's going to be actually beneficial to you. Don't tell people to go run. If they run, they'll stop. They'll hurt and they'll stop. And that's what we see in January all the time. The number of fitness memberships that will be terminated in February is astounding, isn't it? So to prevent a heart attack, take your aspirin, but take it around with you. All right, so we have a strong link between cardiovascular risk and lifestyle factors, yes? Just nod. Okay, this is the exercise for now. Stretch your neck muscles. There is a clear dose response that exists between exercise, physical activity, and cardiovascular risk. Your takeaway, at least 150 minutes per week is desirable. You have a new vital sign that you can put onto your flow forms. Ask, are you exercising? Are you getting enough? 150 minutes per week. The corollary is, are you getting too much time in a chair? Sedentary time also kills you. Maybe Doug will tell us more about that as well. Persons with heart disease have really impaired fitness, and that's a risk factor that's completely modifiable, though. So we can do something about that. If we work together, we can actually improve outcome, including mortality. I think there's a lot on the table that we're still leaving there, and we just don't know about it. We can refer, we can participate, and we can really, really enhance this. We've got lovely programs in Peter Munk and in UHN. We'd love to be working with you on an ongoing basis. And as we build systems for seamless cardiovascular care, I think we can improve outcomes. Thanks for your time, and I'll look forward to questions.
Thank you very much, Paul. I think we'll ask Michael and Vicky to come to the front, and we'll have our question and answers. So how are we doing the question and answers, folks? Are we doing it by microphone, or are we paper? Yeah, okay, so we'll entertain that. I'm going to just sit beside Mike here. So I'm going to begin by a controversial point, I think, and I'll address this to Mike. Mike, we're all going to die, right? I mean, maybe not, but... We
Well,
all
for
are
now,
facing
yes.
mortality. So are we taking away the best way to go? I just have this problem. I mean, it's not like preventing a heart attack. We can't prevent death. We can delay death. And do we have the most nimble and the most robust outcome measure when we talk about types of mortality?
Well, you know, it's an interesting question, because what happens, play that forward just a little bit. What would happen if you really eliminated coronary heart disease or coronary artery disease, presumably stroke as well, and cancer? What would people die of? It would be interesting to understand the ultimate downside. Now, I suppose you may just, by doing that, compress the risk into a relatively narrow period at the end. But it's an interesting question, because I suspect that at the end, the aging process would take over and you'd deteriorate and die. But the exact mode of exit would be sort of interesting to flesh out. I don't think we're really, I suspect that these interventions are not going to quite reach that level, but it could push off these events to what would now be regarded as very late in life. So I think it's worth doing, but the ultimate mode of exit without cancer and heart disease is kind of an interesting question.
So
I
I
don't
think,
have an answer.
do we have the robust measure, though? Is it not the quality of life years